subject of this presentation, which is verbatim the title that I was handed down, is Does Aging Predict Cessation of MS? Immunology of MS in an Aging Population, Clinical Relapses. And I thought I'd reflect briefly on the title. First, as a disclosure, I'm not an aging expert. And in fact, much of the way that I've tried to deal with aging in the context of measuring immune responses, which we've been doing for over a couple of decades, like many others, is to try to balance cohorts that you're comparing for sex and age so that they're matched or at least balanced, without really knowing why we're doing that, being sure that there are reasons for doing that, but not quite understanding what the differences were or what their implications or significance would be. And I've become convinced in the last few years, I think like many others in the community, that aging and thinking of a lifespan condition with some of the themes that we'll touch on today, some of which were raised very beautifully yesterday, is a very important aspect of us thinking about care of individuals living with this type of chronic condition. The title also says Immunology of MS, and I would make the point, and hopefully by the end of this presentation we'll all be convinced, that it's not just the immunology, but it's also the neurobiology, which of course faces very important processes that are age-dependent. And I think, as already highlighted yesterday as well, the immunology and the neurobiology of MS are inexorably linked, and certainly in the context of aging as a theme, they're inseparable. And finally, the term clinical relapses, I think, is inserted into the title because of the more intuitive sense that as the immune system ages, and our classical view of senescence and a less capable immune system is that this would also be perhaps associated, and the reason underlying the decreased frequency of relapse biology in multiple sclerosis, focal inflammatory perivascular lesions. But I hope also to make the case that the aging of the immune system is highly relevant not just to the relapsing biology of the disease as it pertains to cells trafficking from the periphery into the CNS, but also to the CNS compartmentalized inflammation, and again, its interactions with the CNS elements. So this is my disclosure slide. And I thought we'd start by talking about the rationale and why to study aging in MS, a bit of which I touched on already, and then a couple of brief definitions and the implications of normal immune system aging and the CNS, and then finally in the context of MS and MS therapeutics. But first for the rationale, and one important reason, and this is what brought out very nicely some time ago already by Ruth Ann Marie in one of her epidemiology-based studies looking at the large Manitoba MS cohorts, and this is a series of prevalence curves with age distribution on the x-axis, so you can think of as the area under the curve being representative of the number of individuals making up the prevalence in those epochs. The lower line is from 1984, and the higher line, which of course shows many more individuals with MS, is 20 years later, between 1984 and 2004. And the arrows, which are meant to depict more or less the median, will give you a very clear right shift, an older population of MS patients that we are all caring for in the clinic. And of course, MS is a chronic and evolving inflammatory condition that manifests over a good number of decades of life. And the aging of the immune system is going to manifest in changes in many of the elements that have been considered and implicated over the years in MS pathophysiology. And again, that includes participants both in the relapse biology as well as the CNS compartmentalized inflammation that we think of as an important aspect driving non-relapsing progressive disease. And the interactions between immune aging and MS pathophysiology can be thought of from several perspectives. One, of course, does the immune aging process alter MS? And we do think that this is one of the main reasons for lesser relapse biology with increasing age. But might MS alter immune aging? And if so, what might be the significance of that? Do people living with MS immune age faster? And I'll show a few slides that allude to some data, still I think limited in raising more questions than answers, but suggesting that that may be the case. And then, of course, as we have an increasingly aged population, there are more and more aged people exposed to disease-modifying therapies, immune therapies, and might these compound the immune senescence process, which is associated with decreased immune function and hence a safety consideration? Might the immune aging impact the effect of DMTs, the targets, in fact, of the DMTs, thereby impacting their efficacy, and raising very important clinical questions as to when might it be that DMTs are no longer useful, and then the safety efficacy balance, of course, shifts, and might we be thinking in the future of shifting therapies in patients, not just based on the balance between efficacy and safety as we've been thinking of it to date, but also thinking of the interaction with age-related phenomena of the immune system and the central nervous system. And so Emma, I thought, gave, to reiterate Bill's complimentary remarks, Emma's presentation yesterday, I thought also how to be able to be simple but not oversimplistic in trying to think through these very complex processes, and set the stage, making my job easier to sort of superimpose on some of the themes presented yesterday, the aspects of aging. And so you see here a cartoon that I kind of like, going from left to right. You're looking at early MS versus later MS, and again, we can debate what starts it all, but there certainly is a predominance of these focal perivascular inflammatory lesions early in the disease, representing the relapse biology, as I refer to it. We then get collections of immune cells in the meninges that seem to accumulate, perhaps seeded over time, and then becoming part of the compartmentalized inflammation, thought to contribute to aspects of non-relapsing progressive disease. Perhaps the chronic active lesion process may be related to those, or to some aspect of chronicity within the CNS, and that they are contributing in these different anatomic compartments to different ways by which inflammation can contribute to injury in the CNS. So an important point here is that I think this audience already is aware of not defining processes in MS as either inflammatory or degenerative, and that inflammation is not a singular entity. It is different. It has different roles, different players, same players playing by different rules in different compartments over the course of the illness. So there is this complexity, and there's heterogeneity across individuals, which adds a very important layer to the complexity, very pertinent when we're thinking of the therapeutic implications of all of these discussions. And so a very simplified model of MS immune pathophysiology, focusing on the cellular immunology of MS, again highlights immune cells trafficking from the outside in as part of the relapse biology, and then the compartmentalized inflammation, immune-immune interactions, and indeed crosstalk between immune cells and brain cells that we think are relevant to the non-relapsing progressive disease. And this is indeed not a condition, though thought for many years to be T-cell mediated, not exclusively involving T-cells, but with the insights into B-cell biology, it hasn't shifted in my mind to suddenly being a B-cell dominant disease. It really is about interactions between these different cells, both outside of and inside the CNS. And to take a step back, it's worth reflecting on the concept of normal CNS autoimmunity. I imagine that most, if not all of you, appreciate that whereas in the past we used to think that individuals with a condition like MS must have immune cells that can see the central nervous system that healthy individuals don't. In fact, every person sitting in this room right now has B cells and T cells that can recognize many targets within the CNS, including those that we typically try to use to give animals EAE, experimental autoimmune encephalomyelitis. Why we have this normal autoimmunity, we don't fully understand, almost certainly for very important reasons. Normally it is regulated, and it's the relative minority who end up with some imbalance that is enough to shift normal autoimmunity into autoreactivity that causes tissue injury, and that defines the transition from normal autoimmunity to autoimmune disease. Again, even though many of us use the term autoimmunity to imply disease. But normally, we believe that CNS autoimmunity certainly involves the balance between different limbs of the T-cell response effectors and regulators. They don't act alone. They need to see their antigen presented, and here just generically referring to the population of myeloid cells as one important subset. And this subset has different functional subsets within it that can talk back and forth with T cells and shape each other's responses. And as you've heard yesterday, B cells are now no longer viewed as passively awaiting for help and relatively homogeneous, but they too have very important functional heterogeneity, subsets that can differentially impact autoimmunity directly and indeed crosstalk bidirectionally with the different cell types. And the reason to pause on this is to say that there are multiple different immune cell types and their subsets that are interacting normally, and that when they are not properly regulated or balanced, maybe for somewhat different reasons in different individuals, you get an autoimmune disease. And each and every one of these elements is susceptible to aspects of immune senescence and immune aging that we'll touch on. So let's shift gears then to just a couple of definitions. So immune senescence, which is a term that's been used now for a while, really refers to a range of age-associated changes that involve both the composition and the function of multiple different aspects of the immune system, both on the adaptive T cell and B cell, but also on the innate, more myeloid cells, natural killer cells, etc., sides of the immune system, and in general have been viewed to result in a relative weakening of the immune system with age. But there's this other concept that has emerged in the last decade and a half or so that has been referred to inflammaging. And so while immune senescence refers to decreased functionality, inflammaging reflects a chronic lower grade but ongoing active inflammation that seems to increase rather than decrease with age. And immune aging, which can be thought of as the broader term, is driven by complex interactions between immune senescence and immune inflammaging. Another term that I put in brackets that is not so important, but sometimes people use in the immunological parlor, is exhaustion. And this is thought to be and actually now more questions than we thought answers, but an aspect of what is thought to represent chronic activation, so more experience of immune cells, which on average may increase with age, but not necessarily. And that this increase in activation, perhaps persistence of a presence of antigenic encounters, will eventually result in cells changing their functional phenotype and in some ways increasing certain responses and others decreasing, even by the same cell. So an interesting aspect that is linked to age but not dependent directly on age, more on the experience of the cell over time. Now, when we think of the immune system, and to elaborate a little bit on immune senescence versus inflammaging, again, in immune senescence, we're talking about combinations of effects in different organs on different cell types. There's thymic involution, so less new generation of T cell repertoire, and more memory cells, especially CD8 T cells, with reduced frequencies of naive both T cells and B cells. And a process of autophagy, which is a very important process normally, is diminished in the context of immune senescence, and it has implications on a lesser capacity of immune cells to handle debris. Inflammaging, in contrast, involves a variety of elements of the immune system, including a variety of soluble factors, acute phase reactants that become chronically present as acute phase reactants, circulating pro-inflammatory cytokines that would be increased with age, and this increased production of autoantibodies, as well as some changes in the functional phenotype of myeloid and other innate cells that tends to make them more rather than less pro-inflammatory. And these processes are thought to interact in an iterative fashion, shaping each other and collectively contribute to things like increased risk of cancer, infection, diminished vaccine responses in the elderly, but also increased autoimmunity of certain types, but not all, chronic diseases where the immune system is involved, and certainly a range of morbidity and mortality, atherosclerosis being a good example of a condition in which we think of being very much driven and shaped by inflammatory responses that increase rather than decrease with age. The exposome is acting through all its elements on both the immune senescence and inflammaging and their interactions. And the exposome is defined as basically every exposure that one might meet, from the microbiome to chronic infections to cigarette smoking, etc. And you're in for a treat with Sergio, who's going to present on the microbiome work, which is one of his areas of expertise, and one that we've had an opportunity to be a small part of to date, but one that I think a very forward-thinking design of the IMS-MS, which I'm sure he'll elaborate on, the International MS Microbiome Study, is the inclusion of cohabitating individuals with a microbiome study, which allows not only to more efficiently identify MS-specific problems, and has come up with a beautiful Cell paper with really a very, very exciting set of insights into the microbiome in MS versus controls, but also will allow for us to ask about the microbiome over an age span with a pretty balanced age controlled cohort. So when we think of the multiple different compartments that are involved in immune senescence, this involves really all immune organs, but also immune cells resident within tissues where their responses, tissue-resident type cells, become an interesting aspect of fundamental immunology, also will experience changes with age. And again, it's not just what they look like, it's what they can do or cannot do as well. And this busy cartoon, just focusing on T cells, makes the point that there are these multiple different immune organs involved, many changes in the T cell compartment. The ones that are major and measurable in the blood, remember there are many others that may not be measurable in the blood taking place in tissues, is this decrease in naive with increase in memory T cells that I mentioned before, a decrease in the absolute counts of CD8 T cells, perhaps in part causing more infection and cancer, and a decrease in the breadth of the T cell repertoire, likely reflecting multiple exposures that create clonal expansions that then are at the expense, in a sense, of the breadth of the immune response, and possibly limiting its ability over time to respond to as broad a range of new exposures. There are also immune changes that are thought to affect the CNS directly, the healthy CNS, and then perhaps contributing to disease. And so the idea here is that some aspects of immune senescence, such as the thymic involution, imbalances between effector and regulators, together with inflammaging-related changes, will create a low level of chronic inflammation in everybody's CNS, as defined by some increased permeability of the blood-brain barrier and perhaps even a greater infiltration of immune cells into the CNS as part of the low-level normal immune surveillance. Maybe not as capable of doing things, but certainly not absent, and that these may have contributions and very hot area of pursuit in areas of neurodegenerative neurological disease, including Alzheimer's, Parkinson's, but I added MS there because I think highly relevant. And certainly you heard yesterday from Veronica Moran's beautiful talk about the importance of microglia in repair. Microglia and their functional subsets are thought to be involved perhaps in injury as well as in repair, and they are very much susceptible to age-related changes, and that these changes, again, are thought now to be relevant to a range of neurological conditions, including MS, and I'll highlight here Martina Absinta's beautiful paper with Danny Reich that makes the point, very importantly, again, that there's crosstalk on an ongoing basis in health and in disease, including MS, between immune cells that infiltrate and may persist and brain cells like microglia and astrocytes. And there's an important sexual dimorphism, which we've all appreciated and need to learn more about in the context of immune responses, but that this sexual dimorphism also plays out differently with age. And so this busy table that I'm sure no one can really read just makes the point that multiple measurements of immune cell differences between sexes change differently over time in the two sexes. And microglia, just again, are thought to have some very interestingly different features if you isolate them from male versus female, and so I think almost certainly an important interaction between aging and sex and central nervous system homeostasis and disease. So what might be some considerations of all of this in the context of MS and MS therapeutics? And I'll start actually with mechanisms of non-relapsing progressive disease, and without belaboring it, because much of it was identified yesterday, this just lists, in addition to inflammation that was highlighted yesterday, the multiple other mechanisms that we think are pertinent to some aspects of ongoing injury in MS, and each and every one of them is susceptible and influenced by age-associated changes that almost certainly are relevant as we try to think more about MS and later life treatments of MS and not just the peripheral inflammatory process. There are classical immune senescent changes in circulating cells. I highlighted some of the changes already on T cells, but it's true for B cells and for other cells now of the adaptive immune system. And all of these, which happen normally as part of normal immune senescence and are invoked in some aspects of inflammaging, are pertinent, we think, to MS, because in MS, each and every one of these cell types, the subsets, the balances, as I'd mentioned before, are implicated. What about studies of immune aging in people living with MS? Well, there's been this concept of some aspect of premature immune senescence, and earlier studies using markers that immunologists would consider as markers of this sort of chronic activation, if you like, experienced, age-associated, but maybe not, again, because of age, but because of multiple exposures, that cells that have some of those surface features may be increased in proportion or even in absolute counts with age in individuals with MS compared to controls. The significance of these observations not entirely clear. There have been observations, and we did some work both in kids and in adults, showing premature thymic involution or relative decrease in thymic output in adults and in the pediatric population of individuals with MS compared to controls. And Bettina Balint did a very nice paper in which she coined regulatory T cells of children with MS as old cells in young patients on the basis of showing that the Tregs, the regulatory T cell subset of T cells, appear to have properties suggesting greater age, or at least changes consistent with an older individual as compared to healthy controls. This just summarizes some of the recent work that I will absolutely not do justice to, but just to make the point that both in the immunology and neurobiology literature, there's a great deal of interest in these themes, and much done in animal systems where there's no question at all that age makes a difference, and you can move things from a younger to an older animal, including stool, and you can change and shape things in ways that really underscore how the immune system evolution with age has very different consequences to CNS inflammation. In humans, though, studying immune senescence in a condition over decades that has chronic inflammation, so you may measure something that may be a consequence as opposed to a cause, and in a condition where there are now multiple treatments available, it's very difficult to find individuals who are not, for this biological measurement, very confounded, if you like, with immune therapies. So we had an opportunity to put a little story together. It was really an opportunistic cohort. So as you'll see briefly from the data, I just want to do a time check here. Still good, thank you. Is that using multiparametric flow cytometry, fairly standard technique, but multiple panels looking at multiple different immune cell subsets, and I won't go through the details, but happy to share the gating strategy which this represents to capture multiple different subsets and functional phenotypically different subsets of T cells, B cells, and myeloid cells, here focusing the story on the T cells. And the cohort, which is probably a little bit difficult to see, you'll appreciate in the world of MS, we included individuals both with relapsing, remitting, and primary progressive MS, and we can discuss that. The numbers were in the 40s, 50s altogether, so not a huge cohort. We insisted that they not be treated, and in fact, they were never treated. Now that, of course, immediately raises questions as to how representative this population is, because someone who's got MS and is 60 years old, how likely are they to be representative if they've never been treated? Well, one context is when they present at that stage. That doesn't make them the same as the rest of the spectrum, but as you'll see here, what we insisted on is that they not be treated with immune therapy, but they also have manifest clear relapse biology relatively recently. Okay, and so that summarizes the relapse frequency in the prior year, as well as the median time from the last relapse. And in keeping with that, these individuals, as you can see across the cohorts, were relatively recently diagnosed. So again, there are limitations to this, but the main confounder that we wanted to control for was immune therapy. And this is just showing you sort of a heat map of healthy controls on the left, MS patients on the right, and the major subsets of T cells, the CD4 and the CD8 T cells, summarizing on the right first the CD8 T cells. These are the ones that over the years have been shown to have the greatest magnitude changes as part of immune senescence. And you can see the trajectories of decreasing naive and increasing effector memory, as well as the central memory and temporal trajectories. Very similar slopes between the MS and the controls, and for the most part overlapping, perhaps with the exception of somewhat higher frequencies across a broad range of age of central memory CD8 T cells. The CD4 T cells look a little different. Some at the level of major subsets are overlapping, but you'll see that as far as the naive and effector memory balance, there's an imbalance already as early as we looked, and we see this in children, by the way, as well with MS, and that doesn't actually reflect difference in immune aging, because you can see that the trajectories are the same, but the starting point seemingly is different. So we don't quite know what happens really, really early on and what underlies this, but it's an interesting observation. When we then consider the functional subsets, so we're looking now at markers of effector function. First, at the top, you're looking at effector CD8 T cell subsets, and the x-axis is the effect size. So bigger histograms means more of a change with age. You'll see that overall, the CD8 T cells on the top have bigger changes with age as compared to the CD4 T cells on the bottom. But most of the changes with CD8s are very similar between the blue healthy controls and the red MS histograms. Not so for the CD4. So more differences in the CD4 population between MS and controls, although the magnitude of change and magnitude of difference is not as big. And while the CD8 T cells shown on the right, again for these functional subsets at the top expressing interferon gamma, cytotoxic granzyme in the center, and EOMs, which are thought to be, again, age-associated activated cytotoxic cells, no differences on the CD8 side, but quite interestingly, I think, whereas they don't seem to increase much with age in the healthy controls, what looks like a clear increase in the MS patient population. And interestingly, these cells have been identified within the central nervous system at exaggerated numbers, particularly in the context of pathologic changes that one might think associated from what we heard yesterday with progressive as opposed to just focal inflammatory relapsing MS. So there's an implication of these cells in individuals who have progressive aspects of MS, and what the implications are of higher frequencies of them in the circulation as compared to healthy controls, what the implications may be for MS within the CNS and particularly progressive MS is unclear. But just to summarize that, I think many aspects as far as our study is concerned of T-cell immune senescence in MS patients is conserved. The aging patients harbor abnormally increasing frequencies of CD4 cells with activated cytotoxic functions. I didn't show you that they have additional changes that suggest possibly dysregulated B-cell T-cell interaction, and this is totally speculative, as a potential driver based on molecules that are abnormally expressed by the B cells of these patients and would interact with molecules expressed on this particular T cell subset. So maybe a role in progressive disease, and maybe the peripheral response is not entirely separable from consequences to the CNS over time as we think of both immune senescence and therapeutics. And so there I just want to, and I'll briefly go through here more to set up a few minutes for questions and answers, the concept of older patients, which I put in quotes because there are important distinctions between biological age and chronological age, as people refer to. And of course, as we get a little less young by the day, the older definition moves to the right. So most phase 3 trials didn't include patients who are particularly old, so that's important to keep in mind. But this slide was shown yesterday and really shows with age, as depicted here, defined on the x-axis, a decrease in the degree of inhibition with therapeutics of disability progression. Now, I would make the point, though, that I think we'd all recognize that for the most part, these changes in disability progression are more likely to have been contributed to by relapse-related progression of disability. And so I think that this depicts mostly the impact, the differential impact on relapse biology associated worsening in MS, and indeed the relapses decrease and there's less really to target biologically for that aspect of MS. This slide simply makes the point that safety considerations are paramount in individuals as they age normally. Safety considerations in terms of lesser immune surveillance, cancer infection, opportunistic infections included, some of which we know can occur at somewhat higher frequencies with our DMTs in a relatively younger population. What would be the implications when larger numbers of individuals are exposed? And more importantly, can we identify those relatively few individuals who are at risk for particularly bad outcomes and avoid it in them so the others don't have to share that risk and can benefit from the treatment? And this slide is just a reminder that while, yes, relapses decrease and there's less of an impact of DMTs on MS when relapses decrease, this study, which was not large and looked at a subgroup and defined aged as 50 above, which I resent, but bottom line is that this suggests that at least in some people over the age of 50, the balance between efficacy and safety of currently used DMTs is pretty much the same as in the younger individuals, or at least not radically different. So the reason I show this slide is just to make the point that we ought not approach everybody based on age to say you no longer need your DMT. And so treatment decision-making in these older patients, one is a question of, do we start a DMT in someone who presents with MS later in life? And I think we can discuss that. In my mind, it will depend on what we can identify, including subclinically, of focal inflammatory disease, relapse biology that can benefit from current therapies in a reasonable way. And as we start thinking of the next generation of therapies that will target the non-relapsing progressive biology, we'll have to really cope, I think, much more with this question of concurrent therapeutics. Treatment discontinuation or de-escalation mentioned and spoken of about yesterday as well. How do we monitor people? When do we decide? What do we switch to and when? These are important questions. There are, as you know, several ongoing trials, including the DISCOMS, the Discontinue MS Therapy study that was mentioned yesterday, led by John Corboy and others, where we will, I think, within the next year and a half, begin to have data-driven insights into who may be the right person for whom stopping therapy is a good idea versus others for whom one might want to continue the therapy. So we have talked about the importance of early intervention, and yesterday highlighted early intervention with high efficacy therapy if we can keep people safe. And that, I think, is something that continues and we will be doing increasingly, and we will continue to monitor everybody on treatment to make sure that there's nothing happening subclinically for those things we can measure relatively readily in the clinic, which again is more the relapse biology. And hopefully we will be getting tools, perhaps with the PEARLs, the slowly evolving lesions, to capture aspects of the non-relapsing progressive disease in a useful way to monitor in individual patients. That's for G1 and others to prove in the future. The question is what to do with aging, and here this just makes the point that once someone is on a therapy that's working for them, we do need to actively revisit therapy as they age, and just try to integrate as many of these principles and hopefully with more insights, because to date I think still more questions than answers. So just to summarize, MS clearly manifests over decades. Its pathophysiology is superimposed on and almost certainly interacts with both normal immune senescence and inflammaging, which I think has implications both for relapsing and progressive biologies. There are, I didn't talk about this, but there are higher rates of comorbidities, including ones involving chronic inflammation. Is that partly driven by the MS or the interaction of MS with inflammaging and immune senescence? And clearly, major key questions remaining at the level of the DMTs and the implications for vaccine responses. So hopefully circling back to the question as it was posed, I didn't entirely do it injustice, and I thank you all for your attention.